Welcome to the deep dive. This is where we really try to break down those complex medical topics, give you the essential insights you need, and fast.
That's the idea.
Today we're tackling a big one, diabetes mellitus or DM. It's this chronic, multi-system disease that, well, you as future nurses are going to see constantly,
Absolutely.
daily.
And really getting it, understanding it deeply, it's just non-negotiable for good patient care. We're using Lewis's Medical Surgical Nursing as our guide here.
Great resource.
We want to decode DM, its mysteries, how it's managed, and crucially, your role in guiding patients. The mission today, a clear, structured, but also engaging look at the pathophysiology, diagnosis, and especially the nursing management. So, yeah, let's get into it.
And our goal really is to connect that textbook knowledge to what you actually do at the bedside. Diabetes, it's not just about blood sugar numbers.
Yeah. It's about preventing those really serious, life-altering complications, blindness, kidney failure, amputations. And that happens through informed self-management. You're on the front lines of that. So yeah, mastering this stuff, it really makes a tangible difference.
Okay, so let's start right at the beginning. What exactly is diabetes mellitus? We hear high blood sugar all the time, but like you said, it's more complex than that. What's really going on?
You're right. It's definitely more nuanced than just hyperglycemia, that high blood sugar. DM is fundamentally a chronic condition where the body, well, it either doesn't produce enough insulin, or maybe the cells don't use the insulin it does produce effectively, or sometimes it's both.
Okay.
And that leads to that persistently high blood glucose. Over time, that damages, well, pretty much every system in the body. It's a huge health crisis globally.
Yeah.
Here in the US, millions have it, and maybe surprisingly, a lot of people don't even know they have it, which makes your role in early recognition so important. It's also a leading cause of death, mostly because of its link to heart disease and stroke.
Wow. That really puts the scale of it into perspective. What are the underlying causes then? Why does this happen?
It's complicated, and often it's a mix of things. There's definitely a genetic predisposition for some people. Autoimmune reactions play a big role, especially in type 1. And environmental factors, too. Maybe certain viruses or higher body weight is a major factor for type 2.
Okay.
But no matter the trigger, the core issue is that the body's system for processing glucose is out of whack. Either not enough insulin or the body just isn't responding to it like it should.
Gotcha. Before we get into the specifics of type 1 and type 2, maybe just a quick refresher. How is blood sugar supposed to work normally with insulin?
Yeah, good idea. So, insulin, it's a hormone made by the beta cells in your pancreas. Think of it like a key.
Okay.
It gets released, especially after we eat, and its main job is to unlock the doors on our cells, particularly muscle and fat cells, letting glucose move from the bloodstream inside to be used for energy or stored.
Right, the fuel getting into the engine.
Exactly. And this keeps your blood glucose in a pretty tight, healthy range, usually somewhere between, say, 74 and 106 milligrams per deciliter. Now, while insulin lowers glucose, other hormones, glucagon, epinephrine, cortisol, do the opposite. They raise glucose when needed. It's this constant balancing act.
And I remember reading about C-peptide.
Ah, yes. C-peptide is released along with insulin in equal amounts, so measuring it can give us a good idea of how well the pancreas is still making its own insulin. It's a useful indicator.
Okay, that makes sense. Now, let's really differentiate type 1 and type 2. They both end up with high blood sugar, but like you said, they get there differently, and that changes everything for management, right?
Totally different paths, and yes, crucial for you as nurses to get this distinction. You can actually see a great comparison in Lewis's, table 53.1 lays it out clearly. But type 1 DM, it accounts for maybe 5% to 10% of all cases.
So less common.
Much less common. And it's an autoimmune disease. This is the key point. The body's own immune system mistakenly attacks and destroys the insulin-producing beta cells in the pancreas.
The body turns on itself.
Exactly. It usually shows up in younger people, often under 40, but honestly, it can happen at any age. And the result is an absolute lack of insulin production. Zero. These patients cannot make their own insulin.
So they have to have external insulin.
They absolutely have to have exogenous insulin to survive, full stop. The onset is usually pretty sudden. Sometimes it even presents as a medical emergency called Diabetic Ketoacidosis, or DKA. We know genetics are involved, maybe some environmental triggers like viruses, but it leads to this destruction. You often see those classic symptoms pop up quickly: extreme thirst, peeing all the time, really hungry, but losing weight, fatigue.
Okay, so type 1, autoimmune, no insulin production, sudden onset.
Got it. Now, what about type 2 DM? That's the one we see most often, right? Like 95% of cases.
That's the one. And it's a very different story. Type 2 is characterized by a combination of factors. First, there's insulin resistance. The body's cells, especially muscle, fat, and liver cells, don't respond properly to the insulin that is there.
So the key doesn't fit the lock quite right. That's a good way to put it. And second, over time, the pancreas just can't keep up. It gets worn out trying to produce extra insulin to overcome that resistance, and eventually, insulin secretion decreases.
Ah, okay.
But here's the critical difference from type 1. People with type 2 usually do still produce some of their own insulin, at least for a while. That presence of endogenous insulin is why they're generally less prone to DKA than type 1 patients.
That makes sense. And the onset is different, too.
Yeah, much more gradual. It often develops slowly over years. Risk factors are huge here, being overweight or obese, having a family history, getting older, and certain ethnic backgrounds like Native Americans, Blacks, Hispanics, they have higher rates. You can see that risk factor broke down in box 53.2 in the text.
So it's not just one thing going wrong in type 2. It sounds like several metabolic issues happening at once.
Exactly right. Figure 53.3 in Lewis's does a good job visualizing this. You've got that insulin resistance we talked about. Then the pancreas losing its ability to secrete enough insulin. Third, the liver often starts making and releasing glucose inappropriately, even when blood sugar is already high.
Oh, well.
And fourth, those adipokines hormones released from fat tissue can actually promote inflammation and worsen insulin resistance. It's this whole cascade of problems, and it often ties into something called metabolic syndrome.
Right, I've heard of that.
Yeah, it's that cluster. High glucose, abdominal obesity, high blood pressure, high triglycerides, low HDL cholesterol. It's a major red flag for developing type 2 and heart disease.
And because it's so gradual, people might not even know they have it for a long time.
Precisely. Symptoms are often vague, maybe fatigue, getting infections more often, wounds healing slowly, maybe some vision changes. Sometimes a classic thirst and urination too, but often by the time symptoms are noticeable, a lot of beta cell function might already be lost. The disease has been brewing for a while.
What about that stage before full-blown type 2? Prediabetes.
Right, prediabetes. It's that intermediate zone. Blood glucose levels are higher than normal, but not quite high enough to meet the diagnostic criteria for type 2 diabetes. People usually feel fine, no symptoms.
But damage could still be happening.
Yes, that's the key point for you. Long-term damage, especially to the heart and blood vessels, might already be starting silently. But this is also a huge window of opportunity.
For prevention.
Absolutely. Lifestyle changes, losing even a modest amount of weight, eating healthier, getting regular exercise. These can significantly delay or even prevent progression to type 2 DM. It's a critical time for patient education.
And just briefly, there are other types too, like gestational diabetes.
Yes, gestational diabetes develops during pregnancy. It affects a small percentage, maybe 2 to 10%, but it increases risk for both the mom and the baby, and importantly, it raises the mother's risk of developing type 2 later in life. And then there are other specific types caused by certain medical conditions like Cushing's syndrome or even some medications like corticosteroids. So always got to look at the whole picture.
Okay, that clarifies the different types really well. So how do we actually diagnose diabetes officially? What are the specific tests we're looking at?
There are basically 4 ways, and Table 53.2 in Lewis's lists them out. First, an A1C of 6.5% or higher.
That's the long-term average one.
Exactly, reflects blood sugar over the last 2-3 months. Second, a fasting plasma glucose, FPG, of 126 millidl or higher. Fasting means no calories for at least 8 hours.
Okay.
Third, a 2-hour plasma glucose level of 200 milligl or greater during an oral glucose tolerance test, OGTT, where the patient drinks a specific glucose load. And fourth, if someone has those classic symptoms, excessive thirst, urination, unexplained weight loss, a random plasma glucose of 200 milligl or greater is enough.
Got it. And usually you need a repeat test for confirmation.
For the first 3, yes. Generally, you need a repeat test on a different day to confirm, unless the patient is clearly in a hyperglycemic crisis, like DKA or HHS, then one test is enough.
You mentioned the A1C showing the average over months. How does that help specifically in managing diabetes once it's diagnosed?
It's incredibly valuable. It gives us the big picture of overall glucose control beyond just the day-to-day ups and downs. While it doesn't show those moment-to-moment changes, keeping the A1C near normal, the ADA generally recommends less than 7.0% for most adults, is strongly linked to reducing those long-term microvascular and macrovascular complications.
That's a key target.
A major target. And now we also have continuous glucose monitoring, CGM systems. These are becoming much more common.
Right, it's sensors.
Yeah, they measure glucose in the interstitial fluid every few minutes. This gives you trends, patterns, and this idea of time and range, how much time a person spends within their target glucose zone, usually like 70 to 180 milli-GDL. It provides a much more dynamic picture than just A1C or finger sticks alone.
Okay, so once someone is diagnosed, what are the big picture goals of care? And what's in our nursing toolkit?
The main goals are pretty clear. We want to reduce their symptoms, help them feel well, prevent those scary acute complications like DKA or hypoglycemia, prevent or delay the long-term chronic complications, and, of course, keep blood glucose levels as close to normal as is safely possible for that individual.
That makes sense.
You often hear about the ABCs of diabetes A1C, blood pressure, and cholesterol. Managing all three is key. And our toolkit, as you can see summarized in Table 53.3, is really comprehensive. It involves patient and caregiver teaching that's huge, plus nutrition therapy, drug therapy, exercise, and regular blood glucose monitoring. Your role as a nurse in educating and empowering patients for self-management is just absolutely central to all of this.
Let's dig into the drug therapy then. Starting with insulin, it's obviously essential for everyone with type 1, and a lot of people with type 2 end up needing it too. How do we navigate all the different types?
Yeah, it can seem overwhelming at first because there are quite a few. They mainly differ in their onset, how fast they start working, peak, when they have maximum effect, and duration, how long they last. Figure 53.4 in Lewis's gives a good visual of these profiles.
Okay.
We categorize them broadly: rapid-acting, short-acting, intermediate-acting, and long-acting. The goal often is to mimic the body's natural insulin pattern using what's called a basal-bolus plan.
Basal-bolus. What does that mean practically?
It means using two types of insulin. A bolus insulin, which is either rapid-acting or short-acting, is taken before meals to cover the glucose rise from food. And a basal insulin, which is intermediate or long-acting, provides a slow, steady background level of insulin throughout the day and night, mimicking the pancreas's constant low-level output. Table 53.5 shows some examples of these regimens.
Can you give a quick rundown on the timing for these? Like, when does the patient actually take them?
Sure. Rapid-acting insulins, names like Lispro, Humalog, Aspart, Novolog, Glulicine, Apidra, they start working really fast, like within 15 minutes. So the key teaching point is to inject them within 15 minutes of eating, sometimes even right as they start eating. They offer a lot of flexibility.
Okay, very close to mealtime.
Right. Short-acting regular insulin like Humulin R or Novolin R takes a bit longer, maybe 30 to 60 minutes to kick in. So patients need to inject that about 30 to 45 minutes before their meal.
Got it, a little earlier.
Yep. Then for the basal or background insulin, we usually use long-acting insulins. Think Glargine, Lantus, Basaglar, Ditamir, Levemir, Degludec, Tresiba. These are designed to be released very slowly and steadily, often with little or no peak. This provides smooth background coverage and, importantly, reduces the risk of hypoglycemia compared to older intermediate insulins.
Like NPH.
Exactly. Intermediate-acting NPH, Humulin N, Novolin N, can be used as a basal insulin, often twice a day, but it does have a peak, usually around 4 to 12 hours after injection. That peak means there's a higher risk of hypoglycemia if the timing isn't quite right with meals or activity. So long-acting are generally preferred now for basal coverage.
Makes sense. What are some really critical nursing points for actually administering insulin, beyond just the timing?
Oh, several key things. Storage is one. Vials or pens that are currently being used can actually be kept at room temperature for up to 4 weeks, but they need to be kept out of direct sunlight or extreme heat.
Okay, not necessarily always in the fridge once opened.
Correct. Unopened insulin, though, always goes in the refrigerator. Then there's injection technique. It's crucial to teach patients to rotate their injection sites.
Why is that so important?
To prevent lipodystrophy. That's changes in the subcutaneous fat, either atrophy, like dimpling, or hypertrophy, like thickening, which can happen if you inject into the same spot over and over. This can really mess with insulin absorption, making it unpredictable.
Okay, so rotate sites. Where's the best place to inject?
The abdomen generally provides the fastest and most consistent absorption, followed by the arm, thigh, and buttock. We usually teach patients to rotate within one anatomical area for a week or so before moving to a new area. Think of the abdomen like a checkerboard. Use different squares, staying about an inch away from the belly button.
Good visual.
And of course, basics like hand washing, checking the insulin vial for clarity, or uniform suspension if it's cloudy, like MPH, gently rolling cloudy insulins, never shaking, and using the correct injection angle, usually 90 degrees or 45 degrees for very thin individuals. Tale 53.6 outlines these teaching steps well.
Insulin pens and pumps are pretty common now, too. They seem more convenient.
They definitely offer advantages. Insulin pens are pre-filled, portable, more discreet, and can be easier for dosing, especially for people with vision problems. Many have audible clicks for dose selection.
And pumps.
Insulin pumps deliver a continuous subcutaneous infusion of rapid-acting insulin, 247, that's the basal rate. Then the user programs bolus doses to cover meals or correct high blood sugar. This allows for incredible flexibility with meals and activity and can lead to very tight glucose control.
But there are downsides, too.
Yes, definitely challenges. There's a risk of infection at the infusion site, and because the pump only uses rapid-acting insulin, if the infusion gets interrupted, like the tubing kinks or the cannula comes out, the person can quickly develop DKA because they have no long-acting insulin on board. So meticulous site care and troubleshooting skills are essential teaching points. Newer hybrid closed-loop pumps are even smarter, automatically adjusting basal rates based on CGM readings.
You mentioned unpredictable absorption and risks. What about when someone has high blood sugar, specifically in the morning? I remember hearing about the MODY effect and the dawn phenomenon. How do we tell those apart?
Ah, yes, the morning hyperglycemia puzzle. They can look similar, but the cause and treatment are different, so distinguishing them is important. The MODY effect is basically rebound hyperglycemia. It happens when someone takes too much insulin at night, their blood sugar drops too low overnight, often undetected, and then their body releases counterregulatory hormones like glucagon, cortisol to compensate, causing high blood sugar by morning.
So a low followed by a high.
Exactly. Patients might report night sweats, nightmares, or morning headaches as clues to that overnight low. The dawn phenomenon, on the other hand, is more straightforward. It's just the natural increase in blood glucose that happens in the early morning hours for many people due to the normal overnight release of growth hormone and cortisol.
Okay, so how do you figure out which one it is?
The key is checking blood glucose levels between 2.0 a.m. and 4 a.m. If the glucose is low during that time, it strongly suggests the MODY effect. If the glucose is normal or high, it's more likely the dawn phenomenon.
And the treatment differs based on the cause.
Yes. For the MODY effect, the treatment is usually to reduce the evening or bedtime insulin dose to prevent the overnight low. For the dawn phenomenon, the treatment might be to increase the insulin dose or adjust the timing of the evening insulin. So that 2 a.m. check is crucial for getting the management right.
Makes perfect sense. Okay, let's shift gears from insulin to the other medications, mainly for type 2 DM, the oral agents, and the non-insulin injectables. There seem to be a lot of them.
There really are. It's a growing field, which is great because it gives us more tools. Figure 53.8 shows how they work at different sites in the body, and Table 53.8 details the different classes. For you as a nurse, the key isn't necessarily memorizing every single drug name.
Okay, good.
But it is important to understand the major classes, their basic mechanism of action, common side effects, and any really critical nursing alerts or teaching points.
So like metformin, that's usually the first one people try, right?
Yes. Metformin, a biguanide, is typically the first-line therapy for type 2. Its main actions are reducing glucose production by the liver and improving the body's sensitivity to insulin. It generally doesn't cause hypoglycemia when used alone, which is a big plus.
But there's a really important warning with metformin, isn't there?
Absolutely critical. Metformin needs to be temporarily stopped, usually 1 to 2 days before and for 48 hours after any radiologic procedure that involves IV contrast dye. This is to prevent contrast-induced kidney injury, as both the dye and metformin can potentially affect kidney function. That is a major safety point you need to know and teach.
Okay, contrast dye plus metformin, temporary stop. Got it. What about other common classes?
Well, you have the sulfonylureas drugs like glipizide, glyburide, glympyride. These work by stimulating the pancreas to release more insulin. They're effective at lowering glucose, but their major downside is a significant risk of hypoglycemia. Patients must be taught the signs and symptoms of lows and how to treat them.
So hypoglycemia risk is high with those.
Definitely. Then there are newer classes like DPP-4 inhibitors, like sitagliptin Januvia, which work by helping incretin hormones stick around longer. These hormones naturally increase insulin release and decrease glucagon after meals. These drugs usually have a lower risk of hypoglycemia and are often weight neutral.
Okay.
And SGLT2 inhibitors, names like empagliflozin, Jardiance, canagliflozin, Invokana. These work in a totally different way. They block glucose reabsorption in the kidneys, so excess glucose gets peed out.
Interesting mechanism. Any specific warnings there?
Yes, because you're excreting more glucose in the urine, there's an increased risk of genital yeast infections and urinary tract infections. Patients need to know about good hygiene practices. Also, these drugs cause some fluid loss, so dehydration can be a risk, especially initially or in older adults. But they also have shown benefits for heart and kidney protection in many patients.
Wow, lots of different approaches. And there are injectables other than insulin, too.
Yes, non-insulin injectables. The main classes are GLP-1 receptor agonists, like liraglutide Victoza, semaglutide Ozempic, and amylin analogs, pramlintide Simlin. GLP-1 agonists mimic incretin hormones, so they increase insulin secretion, decrease glucagon, slow stomach emptying, and increase feelings of fullness, often leading to weight loss, which is a bonus for many type 2 patients.
Okay.
Amylin analogs, like pramlintide, are used along with insulin, mainly for type 1, but sometimes type 2. Amylin is another hormone normally co-secreted with insulin that helps regulate glucose. Pramlintide slows gastric emptying and suppresses glucagon. But here's a critical point. Because it works alongside insulin, there's a significantly increased risk of severe hypoglycemia. Insulin doses usually need to be reduced when starting pramlintide.
So the big takeaway is that there's this whole range of drugs targeting different parts of the problem in type 2, and each comes with its own benefits, risks, and crucial nursing considerations for patient safety and education.
That's exactly it. It allows for more individualized therapy.
Okay, drug therapy is vital, but we know lifestyle is just as important. Let's talk nutrition and exercise. They're not just nice add-ons, right? They're foundational.
Foundational is the perfect word. Patient-centered nutrition therapy is absolutely essential. And the good news, according to the ADA, is that people with diabetes can generally eat the same healthy foods recommended for everyone else. There's no single diabetic diet.
So what is the focus, then, for teaching?
The focus, as outlined in Table 53.9, is on well-balanced meals with healthy carbohydrates. Think whole grains, fruits, vegetables, legumes, low-fat dairy-managing portion sizes, choosing healthy fats like plant-based oils, nuts, and seeds, and getting lean protein. Fiber is important too. Consistency in timing and amount of carbs can be really helpful, especially for those on insulin.
And weight management, particularly for type 2.
Crucial. For people with type 2 who are overweight or obese, even losing a modest 5% to 7% of their body weight can dramatically improve insulin sensitivity and blood glucose control, potentially reducing the need for medications.
What about alcohol? Is that off limits?
Not necessarily, but it needs careful management. Alcohol can inhibit the liver from producing glucose, which significantly increases the risk of hypoglycemia, especially if someone is taking insulin or sulfonylureas and drinking on an empty stomach.
Okay.
So the advice is usually moderation, 1 drink per day for women, up to 2 for men, and always consuming alcohol with food to prevent that drop in blood sugar.
Yeah.
And checking glucose levels is important. Using sugar-free mixers is also a good tip.
Got it. And exercise. We know it's good for us, but what specifically does it do for diabetes management?
Exercise is incredibly powerful. It does much more than just burn calories. Regular, consistent activity, the general recommendation is 150 minutes per week of moderate intensity aerobic exercise, like brisk walking, plus resistance training 2-3 times a week, directly decreases insulin resistance.
So it makes the body's own insulin work better.
Exactly. It helps muscle cells take up glucose more effectively, even without insulin. This often leads to lower blood glucose levels and can reduce the need for diabetes medications.
But there's a flip side, right? The risk of lows during or after exercise.
Yes, that's the critical safety consideration, especially for anyone using insulin or sulfonylureas. Exercise increases glucose uptake by muscles, which can lead to hypoglycemia if medication or food isn't adjusted. And this effect can sometimes last up to 48 hours after intense or prolonged activity.
Wow, 48 hours. So what are the key teaching points around exercise safety?
Table 53.11 gives detailed guidelines. Some key ones include checking blood glucose before exercising. If it's low, say under 100 milligdl, eat a small carbohydrate snack, like 10-15 grams first. Always carry a fast-acting carbohydrate source during exercise, just in case.
Okay.
For type 1 patients, it's important not to engage in vigorous activity if their blood glucose is high, over 250 milligdl, and they have ketones present in their urine. This could actually worsen hyperglycemia and ketosis. And knowing how different types of exercise might affect their glucose differently is also part of the learning curve.
So tying this all together, the food, the activity, the meds, how do patients actually track what their glucose is doing moment to moment, day to day?
That's where blood glucose monitoring, BGM, comes in. It is absolutely critical for self-management. It empowers patients to see how their choices, food, exercise, medication doses, are impacting their glucose levels in real time.
How often should people be checking?
It really varies depending on the person, their type of diabetes, their treatment plan, and their goals. For people using multiple daily insulin injections or an insulin pump, checking 4 to 8 times a day is pretty standard before meals, sometimes 2 hours after meals, at bedtime, and maybe occasionally overnight or before after exercise.
And they use those little meters with the finger sticks?
Yep, portable blood glucose meters. The usual technique involves a small prick on the side of the fingertip, not the pad, as it's less sensitive. Table 53.12 details the teaching points for using a meter correctly.
And you mentioned continuous glucose monitoring, CGM, earlier. How does that fit in?
CGM provides a much more continuous picture. A sensor inserted under the skin measures glucose in the interstitial fluid every 1 to 5 minutes and sends the readings to a receiver or smartphone. This helps patients and providers see trends, patterns, overnight lows, or post-meal spikes much more easily. The goal with CGM is often to maximize that time in range we talked about, keeping glucose between 70 and 180 mg/dL as much as possible. It's really changing diabetes management for many.
For some specific severe cases, aren't there transplant options too?
Yes, for a select group of patients with type 1 diabetes, particularly those who also have end-stage kidney disease and are already getting a kidney transplant, a pancreas transplant can potentially cure the diabetes, eliminating the need for insulin injections and BGM. However, it's major surgery with significant risks and requires lifelong immunosuppression. Pancreatic islet cell transplantation, where just the insulin-producing cells are transplanted, is less invasive but still considered somewhat experimental and often doesn't provide lasting insulin independence. So these aren't common solutions but are options in certain situations.
Okay, let's pivot now specifically to the nursing process. When you're assessing a patient who either has diabetes or might be at risk, what key subjective and objective data are you looking for?
A really thorough assessment is crucial. Table 53.13 in Lewis's is a great guide here. Subjectively, you want to ask about their health history, any past viral infections, recent major stress or trauma, pregnancy history, and definitely family history of diabetes. Ask about medications, especially corticosteroids or phenytoin, which can raise glucose.
And their current symptoms.
Yes. Probe those functional health patterns. Ask about excessive thirst, polydipsia, excessive hunger, polyphagia, frequent urination, polyuria. Ask about fatigue, poor wound healing, any recurrent infections, muscle weakness, blurred vision. Importantly, ask about numbness or tingling in hands or feet, neuropathy. And don't shy away from asking about issues like erectile dysfunction in men or depression, which are common comorbidities.
And objectively, what are you looking for during the physical exam and labs?
Objectively, you might see signs of dehydration like hypotension, dry mucous membranes, maybe even soft, sunken eyeballs in severe cases. A fruity breath odor is a classic sign of DKA. Look for Kussmaul respirations, those rapid, deep breaths trying to blow off acid in DKA. Check the skin for dryness, lesions, or signs of poor circulation, and of course, vital signs and weight. Key lab findings would be elevated fasting glucose, elevated A1C, and potentially glucose or ketones in the urine, glycosuria, ketonuria.
With all that assessment data, what are the overarching goals we set for the patient?
The goals really center on empowering the patient. We want them to be actively engaged in their self-care behaviors. We aim to prevent those acute hyperglycemic or hypoglycemic emergencies. We want to help them maintain blood glucose levels within a safe, individualized target range to reduce the risk of those long-term complications. And ultimately, we want them to be able to adjust their lifestyle to accommodate diabetes management with minimal stress. The goal isn't for diabetes to run their life, but for them to safely and effectively fit diabetes management into their life.
So how do we, as nurses, help them achieve those goals? What are our key interventions or implementations?
Our actions cover several critical areas. First is health promotion. This means identifying patients who are at risk for developing type 2 diabetes. Table 53.14 outlines screening criteria generally. Screening is recommended for all adults who are overweight or obese and have at least one other risk factor, or for everyone starting at age 45 with repeat testing every 3 years if normal.
And if they are at risk?
Then primary prevention strategies are key. Box 53.3 details these things like aiming for that 150 minutes of moderate activity per week, maintaining a healthy weight, making balanced dietary choices. These lifestyle changes can seriously lower the risk of developing type 2 DM by as much as 34% to 58% in high-risk groups. So education starts even before diagnosis.
What about patients who already have diabetes, especially during times of acute illness or surgery? That seems like a particularly vulnerable period.
It absolutely is. Any kind of stress, whether emotional like anxiety or physical like infection or surgery, can raise blood glucose levels. So we need to teach patients sick day rules.
Sick day rules.
Yes. This means checking blood glucose more often, usually at least every 4 hours, even if they're not eating much. For type 1 patients, if their glucose is high, say over 240 milligdl, they also need to check their urine for ketones every 3 to 4 hours. They need clear instructions on when to contact their healthcare provider, for example, if glucose stays over 300 milligdl on 2 consecutive checks, or if they have moderate to large ketones. They should continue taking their insulin or oral agents as prescribed, even if nauseous, and stay well hydrated.
And during surgery.
During surgery, patients are often managed with IV fluids and IV insulin to maintain glucose control, especially if they're NPO. Post-operatively, careful monitoring continues as healing occurs. Table 53.15 provides a good summary of nursing management points across different settings, covering everything from risk assessment to managing complications and ongoing teaching.
For the day-to-day management in the community or clinic setting, how do nurses really empower patients to handle this complex disease on their own?
The goal is always to foster independence and self-efficacy. We start by assessing their ability and their caregiver's ability, if involved, to perform essential tasks like BGM and insulin injections. We need to consider any limitations, poor vision, arthritis affecting dexterity, cognitive issues, and adapt our teaching accordingly. Use teach-back methods.
Right.
We use an empowerment approach, treating the patient as a partner in their care, respecting their choices, and helping them problem solve. Tables $53.16 and $53.17 provide really comprehensive checklists for patient teaching, covering the disease process, medications, exercise, meal planning, monitoring, risk reduction, everything.
And you mentioned foot care earlier. That seems like a recurring theme.
It is paramount. Because of the risks of neuropathy, loss of sensation, and peripheral artery disease, poor circulation, foot complications are incredibly common and can lead to ulcers and amputations. So rigorous personal hygiene, especially meticulous foot care, is a non-negotiable teaching point.
What does that involve specifically?
Table 53.23 details this really well. It includes inspecting their feet every single day, using a mirror if needed to see the bottoms, washing feet daily with mild soap and warm water, testing water temp first, patting feet dry gently, especially between the toes, applying lotion to dry areas but not between the toes, wearing well-fitting shoes and clean, dry socks, never going barefoot, cutting toenails straight across and filing edges smooth, and seeking professional care immediately for any cuts, sores, blisters, or infections, no matter how minor they seem.
That's incredibly important detail. What else for daily life?
We also counsel patients on always carrying medical identification, a bracelet or card stating they have diabetes, and planning ahead for travel is important, especially crossing time zones or having different activity levels, which can affect insulin needs and timing. It's about anticipating and planning.
Okay, let's shift to the acute complications. These are the emergencies where quick recognition and action are critical. How do we tell them apart, and what do we do?
Right. This is where knowing the signs and acting fast can save a life. Table 53.18 gives a good comparison of hyperglycemia versus hypoglycemia symptoms. The major hyperglycemic crises are DKA and HHS.
Let's start with DKA. What are the hallmarks?
Diabetes-related ketoacidosis, DKA, which figure 53.12 illustrates, is caused by a profound lack of insulin, so it's seen primarily in people with type 1 diabetes, although it can occur in type 2 under severe stress. It's characterized by four main things: hyperglycemia, high blood sugar; ketosis, ketones in blood and urine; acidosis, low blood pH; and dehydration.
What triggers it?
Often illness or infection, inadequate insulin dosage, undiagnosed type 1 diabetes, or poor self-management. Clinically, these patients look sick. They're severely dehydrated, think tachycardia, orthostatic hypotension. They might be lethargic or weak. Abdominal pain, nausea, and vomiting are common. And the classic signs, that distinct fruity breath odor from ketones and Kussmaul respirations, those rapid, deep breaths the body uses to try and compensate for the metabolic acidosis.
And labs confirm it.
Yes. Labs show glucose levels typically 250 milligl or higher, arterial blood pH less than 7.30, serum bicarbonate less than 16 MEQL, and moderate to large ketones in the urine or blood.
Okay, it's DKA. What's emergency management? Table 53.20 outlines this.
Yes, Table 53.20 covers it. The first priority is usually fluid resuscitation to correct the dehydration and improve circulation. This typically starts with IV infusion of 0.45% or 0.9% sodium chloride. Once blood pressure is stable and urine output is adequate, we start a continuous IV infusion of short-acting regular insulin to lower the glucose and stop ketone production.
And you mentioned something critical about adding dextrose later.
Absolutely crucial. As the IV insulin brings the blood glucose down, typically when it approaches 250 mg/dL, we add 5% or 10% dextrose to the IV fluids. This seems counterintuitive, but it prevents hypoglycemia and also helps prevent a potentially dangerous complication called cerebral edema, which can happen if glucose drops too quickly.
And potassium.
Potassium management is vital. Initially, the patient might have normal or even high potassium levels, but insulin drives potassium into the cells along with glucose. So as we treat with insulin, potassium levels can drop rapidly and dangerously, causing cardiac dysrhythmias. We need to monitor potassium levels very closely and replace it intravenously as needed before levels get critically low. Continuous ECG monitoring is essential. Throughout this, nurses are monitoring vital signs, level of consciousness, intake, and output in those key labs very frequently.
Okay, that's DKA. What about HHS? You said it's different.
Right. Hyperosmolar Hyperglycemia Syndrome, HHS, shown in figure 53.13, is less common than DKA and usually occurs in older adults with type 2 diabetes. The absolute key difference is that patients with HHS typically produce enough circulating insulin to prevent the body from breaking down fat for energy so they don't develop ketoacidosis.
No ketones, no fruity breath, no acidosis.
Exactly. But they still experience severe hyperglycemia, osmotic diuresis, losing tons of fluid, and profound dehydration. Often it's triggered by an infection like pneumonia or a UTI, and someone with type 2 may be combined with factors that impair thirst sensation or ability to replace fluids.
In the clinical picture.
Because they don't have the acidosis symptoms like DKA, HHS can sometimes develop more slowly. But the hyperglycemia gets extremely high. Glucose levels are often way above 600 mg/dL. This leads to a massive increase in serum osmolality, essentially making the blood very concentrated, which pulls water out of cells, including brain cells. This results in more severe neurological manifestations than typically seen in DKA, things like somnolence, coma, seizures, hemiparesis, aphasia. It can really mimic a stroke.
Wow. So very high glucose, severe dehydration, neurological changes, but no ketone acidosis. How is it managed? Similar to DKA.
Management overlaps significantly, but with some key differences. Immediate 5E insulin and massive fluid replacement are still the cornerstones. However, HHS often requires even larger volumes of fluid replacement than DKA because the dehydration is often more profound. This needs to be done carefully and slowly, especially in older patients who might have underlying heart or kidney problems.
And dextrose and potassium.
Same principles apply. Dextrose is added to the IV fluids when glucose levels fall to around 250 mg/dL to prevent hypoglycemia. Potassium needs careful monitoring and replacement as insulin therapy begins. The focus is on restoring fluid volume, correcting the hyperglycemia gradually, and monitoring neurological status very closely.
Okay, so DKA and HHS are the major hyperglycemic crises. Now let's flip to the other extreme, which can be even more immediately dangerous. Hypoglycemia.
Yes, hypoglycemia or low blood glucose, defined generally as glucose below 70 mg/dL. This happens when there's too much insulin circulating in proportion to the available glucose, maybe from too much medication, missing a meal, unplanned exercise, or drinking alcohol without food.
What does it feel like? What are the signs?
The body's initial response is to release epinephrine, adrenaline. This causes those adrenergic symptoms: shakiness, tremors, palpitations, nervousness, anxiety, diaphoresis, sweating, intense hunger, and pallor.
The fight or flight response kicks in.
Exactly. But if the glucose continues to drop and the brain isn't getting enough fuel, that's neuroglycopenia symptoms change, you might see difficulty speaking, slurred speech, visual disturbances, stupor, confusion, loss of coordination, irritability, even loss of consciousness or seizures. These symptoms can sometimes be mistaken for alcohol intoxication.
That's scary. And some people don't even get those early warning signs.
That's a critical concern called hypoglycemia unawareness. The person doesn't experience those initial adrenergic warning symptoms like shakiness or sweating. They might go directly to the neuroglycopenic symptoms like confusion or loss of consciousness. This is more common in people who've had diabetes for a long time, have had frequent episodes of hypoglycemia, or have autonomic neuropathy. It makes them much more vulnerable to severe lows.
So if someone suspects they're having hypoglycemia, or you see these signs, what's the immediate action?
If their blood glucose is confirmed below 70 mg/dL, or if they have symptoms and testing isn't immediately possible, the immediate action is the Rule of 15. You can find this detailed in Table 53.21.
Rule of 15, what is that?
It means ingest 15 grams of a simple, fast-acting carbohydrate. Wait 15 minutes, then recheck blood glucose. If it's still below 70 mg/dL, repeat the 15 grams of carbs.
What counts as 15 grams of fast-acting carbs?
Good examples are 4 to 6 ounces, about half a cup of fruit juice or regular soda, not diet, 5 to 8 Lifesavers candies, 1 tablespoon of sugar or honey, or glucose tablets or gel specifically designed for this purpose. The key is simple carbs avoid things with fat, like chocolate or cookies, because fat slows down glucose absorption.
Okay, 15 grams, wait 15 minutes, recheck, repeat if needed. What if the person is unconscious or can't swallow?
That's a medical emergency. In a healthcare setting, the treatment is typically 20 to 50 milliliters of 50% dextrose solution given IV push. If there's no IV access, or in an out-of-hospital setting, 1 milligram of glucagon can be given by intramuscular, IM, or subcutaneous injection. Glucagon stimulates the liver to release stored glucose. An important nursing point with glucagon is to turn the patient on their side after administration, as nausea and vomiting can be side effects, and you want to prevent aspiration.
And after the immediate episode is treated.
Once the glucose is back above 70 mg/dL and the person is stable, they should have a more complex carbohydrate snack or meal to prevent recurrence, especially if their next meal is more than an hour away. And critically, always try to investigate why the hypoglycemia happened: too much insulin, missed meal, unusual exercise, to try and prevent it from happening again.
Okay, those acute complications are definitely emergencies needing fast action. But beyond those crises, the long-term chronic effects of diabetes are where so much damage can occur over time. This really highlights the need for ongoing, diligent nursing care, doesn't it?
It absolutely does. This is where consistent management and patient education make the biggest difference in quality and length of life. Chronic complications are primarily the result of angiopathy, which is damage to blood vessels caused by chronic hyperglycemia. This is why diabetes is a leading cause of cardiovascular disease, stroke, blindness, kidney failure, and amputations.
How does high blood sugar actually damage the vessels?
It's complex, but chronic hyperglycemia leads to the accumulation of damaging byproducts like sorbitol and causes abnormal glucose molecules to attach to proteins in vessel walls, changing their structure and function. This happens in both large and small blood vessels. The landmark study, a Diabetes Control and Complications Trial, DCCT, and its follow-up, clearly showed that keeping blood glucose levels as close to normal as possible significantly reduces the risk for these microvascular complications. So ongoing monitoring for these issues, as outlined in Table 53.22, is essential.
Let's break them down. What are the macrovascular complications?
Macrovascular complications affect the large and medium-sized blood vessels. This leads to cardiovascular disease like heart attacks, cerebrovascular disease, strokes, and peripheral vascular disease, poor circulation, especially in the legs and feet. Diabetes significantly accelerates atherosclerosis, the hardening and narrowing of arteries.
And other risk factors play a role too.
Oh, definitely. Modifiable risk factors like obesity, smoking, high blood pressure, and high cholesterol dramatically increase the risk of macrovascular disease in people with diabetes. This really raises an important question for us as nurses. How effectively are we teaching patients about controlling all these risk factors, not just blood sugar?
That's a great point.
Optimizing blood pressure, usually aiming for less than a 440/90 millimeter Hg, though sometimes lower targets are set, and managing lipids, often with statin therapy, regardless of baseline cholesterol levels in many adults with diabetes, are absolutely critical. And smoking cessation. Smoking just wreaks havoc on blood vessels, hugely increasing the risk, especially for peripheral artery disease and subsequent amputation. We have to be relentless about smoking cessation support.
Okay, so that's the large vessels. What about the microvascular complications? These affect specific organs, right?
Yes, microvascular complications result from thickening of the vessel membranes in the capillaries and arterioles, again due to chronic hyperglycemia. The main targets are the eyes, the kidneys, and the nerves.
Let's start with the eyes, retinopathy.
Diabetes-related retinopathy is microvascular damage to the retina, the light-sensitive tissue at the back of the eye. It's the most common cause of new cases of adult blindness in developed countries. It ranges from non-proliferative retinopathy, where tiny capillaries leak fluid or blood, causing retinal edema and potentially blurred vision, to proliferative retinopathy, which is more severe. In this stage, the retina tries to compensate for poor circulation by growing fragile new blood vessels, which can easily bleed into the eye, cause scar tissue, or even lead to retinal detachment and severe vision loss.
How do we prevent or manage that?
Early detection and treatment are key. That's why annual dilated eye exams are recommended for almost everyone with diabetes. Maintaining tight glucose control and managing blood pressure significantly reduce the risk and progression. Laser photocoagulation therapy can often treat leaking vessels or shrink abnormal new ones if caught early enough.
Okay, eyes. Next, kidneys. Nephropathy.
Diabetes-related nephropathy is damage to the small blood vessels that supply the glomeruli, the filtering units of the kidneys. It's the leading cause of end-stage renal disease, ESRD, in the United States, requiring dialysis or kidney transplant.
How do we screen for that?
Annual screening is recommended. This involves checking the urine for microalbuminuria, small amounts of albumin leaking into the urine, which is an early sign of damage, and measuring serum creatinine to estimate kidney function, glomerular filtration rate, or GFR. Keeping blood pressure well controlled, often using specific medications like ACE inhibitors or ARBs, is crucial for protecting the kidneys and slowing the progression of nephropathy, even in people without high blood pressure if they have albuminuria. Tight glucose control is also essential.
And the third target, nerves. Neuropathy.
Diabetes-related neuropathy, or nerve damage, is incredibly common, affecting maybe 60% to 70% of people with diabetes over time. The most common type is sensory neuropathy, specifically distal symmetric polyneuropathy.
That sounds complicated. What does it mean?
It basically means damage to the peripheral nerves, usually starting in the toes and feet and gradually progressing upwards, often affecting the hands too, sometimes called a stocking glove pattern. Patients might experience loss of sensation, abnormal sensations like burning, cramping, or tingling paresthesias, or sometimes hypersensitivity. Or they might feel like they're walking on pillows because they can't feel the ground properly.
And the big danger there is?
The loss of protective sensation, or LOPS. Because they can't feel pain, pressure, or temperature normally in their feet, they can develop injuries, blisters from ill-fitting shoes, cuts, burns without even realizing it. These minor injuries can then easily become infected and develop into serious foot ulcers, potentially leading to amputation. This is why foot care is so critical.
Is there treatment for the nerve damage itself?
Unfortunately, the only treatment to slow the progression of the underlying nerve damage is maintaining good blood glucose control. However, we can treat the painful symptoms of neuropathy with medications like certain antidepressants, duloxetine, amitriptyline, or anti-seizure drugs, gabapentin, pregabalin.
Are there other types of neuropathy besides sensory?
Yes, autonomic neuropathy. This affects the nerves that control involuntary bodily functions: heart rate, blood pressure, digestion, bladder function, sexual function. It can cause a wide range of problems. Hypoglycemia unawareness, because the body doesn't release those warning hormones properly. Gastroparesis, delayed stomach emptying, which can cause nausea, vomiting, and unpredictable blood sugar swings. Postural hypotension, dizziness when standing up. A neurogenic bladder, difficulty emptying completely, leading to UTIs. And erectile dysfunction in men, which is often an early sign.
Wow. It really affects almost everything.
It really can. And when you combine that sensory neuropathy, LOPS, and autonomic neuropathy, maybe decreased sweating leading to dry, cracked skin, with peripheral artery disease, poor blood flow for healing, you have the perfect storm for complications of the feet and lower extremities. That's why foot ulcers and amputations are such a major concern. Annual screening with a monofilament test to detect LOPS is vital, along with all that patient education on daily foot inspection and proper footwear we talked about.
Are there other complications, maybe involving the skin or infection risk?
Yes, people with diabetes can develop specific skin complications. Diabetic dermopathy, small pigmented lesions on the shins, acanthosis nigricans, dark velvety patches often on the neck or armpits, indicating insulin resistance, and necrobiosis lipoidica diabeticorum, uncommon red-yellow lesions, are some examples. Also, people with diabetes are definitely more susceptible to infections.
Why is that?
Chronic hyperglycemia can impair the function of white blood cells, reducing their ability to fight off bacteria and fungi. Plus, poor circulation can hinder the delivery of immune cells and antibiotics to infected areas. Recurring infections like candida, yeast infections, boils, or UTIs can sometimes even be the first sign that someone has undiagnosed diabetes. So, prompt and aggressive treatment of any infection is crucial, along with preventative measures like good hygiene and recommended vaccinations, like flu and pneumococcal.
It's clear the physical impact is huge, but diabetes doesn't just affect the body, does it? There's a significant psychological aspect, too, and challenges particularly for older adults.
Absolutely. We can't overlook the psychosocial burden. People with diabetes have significantly higher rates of emotional distress, anxiety, and depression compared to the general population. Feeling overwhelmed by the demands of self-management, worrying about complications, dealing with the chronicity of it all, it takes a toll. And importantly, these mental health issues can directly impact their ability and motivation to perform self-care tasks, creating a vicious cycle.
Are there specific issues like eating disorders?
Yes, unfortunately. Disordered eating behaviors can occur, including something sometimes called diabulimia. This is where someone with type 1 diabetes intentionally reduces or skips their insulin doses in order to lose weight. This is incredibly dangerous and can rapidly lead to DKA and accelerate long-term complications. It really underscores the need for open, non-judgmental communication with patients about their emotional well-being and readiness to refer them to mental health professionals when needed.
And thinking about the aging population, diabetes is really common in older adults.
Extremely common. Over 25%, maybe even higher, of people over age 65 have diabetes. The aging process itself can contribute to insulin resistance and decreased beta cell function. Plus, diagnosing it can be trickier in older adults because classic symptoms might be absent, or things like low energy, fatigue, or confusion might be mistakenly attributed just to getting older.
What are the unique challenges for managing diabetes in this age group?
There are several. Older adults are often at higher risk for hypoglycemia and may have more pronounced hypoglycemia unawareness. They might have other chronic conditions, comorbidities requiring complex medication regimens, increasing the risk of drug interactions. Functional limitations like impaired vision, hearing loss, mobility issues, or cognitive decline can make self-management tasks like BGM or insulin injection difficult or impossible without assistance.
So our nursing approach needs to be adapted.
Absolutely. Teaching plans must be individualized, taking into account their specific cognitive and physical abilities, their support system, and their personal goals for care, which might prioritize quality of life over achieving the tightest possible glucose control if that comes with excessive risk of hypoglycemia. Involving family members or caregivers is often essential. Our assessment and interventions need to be really tailored to the unique needs and circumstances of the older adult with diabetes. It requires a very holistic and patient-centered perspective.
Wow, that was an incredibly thorough deep dive into diabetes mellitus. We've covered so much, from the basic pathophysiology and different types, through diagnosis, the complexities of drug therapy, the crucial role of lifestyle management and monitoring, the nursing process, those acute emergencies, the devastating long-term complications, and the psychosocial aspects.
Yes.
It's crystal clear that this disease demands constant vigilance, continuous learning for us as nurses, and a truly holistic approach to patient care.
It really does. And maybe this raises an important question for you as you move forward. How will you personally empower your patients? It's not just about giving them information about their disease. It's about helping them translate that knowledge into sustainable, healthy behaviors that fit their lives. How will you help them build the confidence and skills for true self-management? Your empathetic guidance, your ability to listen and problem solve with them, that's going to be just as vital as any medication or procedure we've discussed.
That's a fantastic thought to end on. Thank you for joining us for this deep dive into diabetes mellitus. We really hope you feel more confident, more prepared to tackle this incredibly important topic in your studies and, most importantly, in your future nursing practice. From all of us here at the Deep Dives, and a warm thank you from the Last Minute Lecture team, thanks for listening.